I would speculate that you would give, the allopregnanolone that's available by IV for a low price of around $20,000 for 14 days, something like that. This is probably this line right here that we have, this row is probably what I would consider the closest to the root cause. As far as a treatment that we have, potentially downstream. I think that this one is only available as an injection still, just like brexanolone, which would probably work also. But
Yes.
Basically, this is isoallopregnanolone, as you alluded to earlier. This is also a metabolite of progesterone, just as allopregnanolone is. So I would speculate that you would give, the allopregnanolone that's available by IV for a low price of around $20,000 for 14 days, something like that.
Yep.
You're
Good
probably,
and accessible to all, regardless of insurance.
You probably are going to get the same effect there, stabilizing the GABA A signaling during this time period. Hopefully they get some sort of an oral form of this, because this is I think a 2017 trial that Dr. Bristow pointed out. I think it was a 2017 paper where we know this works, but we don't have anything that, as far as I'm aware, is in phase 3 or soon to come out. I think it's still in the development phase.
I believe the same company owns the rights to this, which is the GABA A antagonist, isoallopregnanolone. Brexanolone, as you mentioned, is allopregnanolone. And by the way that I think of these two is similar to T3 and reverse T3. So T4 is your main thyroid hormone, and then it converts to T3, your active thyroid, and reverse T3, your inactive thyroid hormone. And they balance each other out, almost like a tug of rope. And the same thing is the case for isoallopregnanolone and allopregnanolone. They also balance each other out. And when that doesn't happen, then I suppose you could say you get PMS or PMDD. It would be very interesting for that drug company to do a trial on a combination of isoallopregnanolone and allopregnanolone at the correct ratio, whatever that is. I'm not sure if it's 50-50. So if somebody from that company is listening, then give it a try and shout us out for the idea.
The documents have actually revealed that combination product comes out 10 years later after the patents on the originals expire, as is custom.
That makes a lot of sense. Yeah, you wouldn't want to have a product come out where your patents would stack, because then your company wouldn't make enough money to fund future research for future yachts and trips to the Caribbean.
Bingo. Teasing aside, we do poke fun at the pharmaceutical industry, just as we do the traditional, medical treatment guidelines and people that work in those organizations. But we do like to keep our nice guy reputations intact, but we also like to have fun.
Yeah.
All right. So then they have, we talked about, this looks like a repeat of the same. Yeah, we talked about the synthetic progestin.
We did.
The quetiapine.
Yep.
And then here's with no evidence, mixed evidence, or negative evidence. Lifestyle changes.
It seems like a good idea. We like to say lifestyle changes are more powerful than any pill or supplement.
Yeah, so I think I mentioned earlier alcohol, that's going to destabilize GABA for sure. And people, even men will sometimes get rebound anxiety after a night of drinking. And this is not just waking up, feeling shaky and so forth. Some people will have a severe uptick in anxiety. It's okay, it's a pretty good sign to not do that again. And then reducing caffeine, this certainly makes sense because you don't want more norepinephrine circulating and increasing heart rate and stimulating an anxiety response. Some people have an anxiety response to caffeine at baseline. And then the other thing, it actually doesn't mention stress there, but limiting stress would be a pretty good idea, because we know that anxiety and depression definitely have a stress-induced component to them.
Yeah. I'll take this opportunity to put my functional medicine tinfoil hat on and mention MSG, monosodium glutamate. Perhaps, along with alcohol, very reasonable to avoid the last 7 to 10 days of the menstrual cycle. We'll talk about some other things like agmatine later, but the glutamate excitotoxin pathway is something that perhaps should be thought about and try it, and there's very little downside to avoiding MSG and alcohol. See how you feel.
I speculate it's got a better risk-benefit profile than having your uterus and ovaries removed.
Yeah, I think so as well. And there's many people that, at least anecdotally in the functional medicine community, that avoid MSG and alcohol at certain times of the cycle, and it seems to work well. The devil's advocate to that would be, of course, placebo works particularly well in not only PMDD and PMS, but also in postpartum blues and postpartum depression.
Yeah, any pathology where there's any kind of psychiatric overlap, you have a robust placebo response, which makes it even harder to develop effective agents around that, or easier if you don't reveal the statistics in the placebo group.
Yeah, and that's likely why bioidentical hormone treatments with isoallopregnanolone or allopregnanolone have trouble proving efficacy, is because it works extremely well, but the placebo also works 40-50% of the study group.
Yeah, for sure. The other one here, vitamin and mineral supplements. We'll talk about what we think might be beneficial here, vitamin and supplement wise, things you could get over the counter. I don't think it's a bad idea having adequate calcium, magnesium, vitamin D, and B6, either in your diet or in a supplemental form. The calcium one is interesting because this doesn't relate to sort of what we've been focusing on is the progesterone and progesterone metabolism. There's an estrogen-dependent flux in calcium level. I don't know if this comes from the action on osteoclasts and bone resorption, but it might make sense if you have a swing of estradiol from 300 at ovulation down to 50 in your follicular phase. But there is some fluctuation in calcium level there, and there's a few small trials that have seen somewhere around 1,000 milligrams of calcium have been beneficial in this luteal phase to kind of stabilize that. Again, not nearly as effective as some of these other things we talked about, but not a lot of downside to that. Obviously, talk to your doctor and nurse practitioner. Some people are not good candidates to take extra calcium, and you should know that.
This is also a good time, this being the luteal phase, to implement the Huberman sleep stack. You sleep a bit better, you feel a bit better during the day. L-theanine is going to increase the alpha waves in the brain, almost like meditation and prayer, which is also good to do. And the magnesium is going to help you be a bit more relaxed, sleep a bit better. That'd be mag-glycinate or mag-threonate. And then on top of that, I like to add in inositol. So inositol can also help with sleep. If you're depleted, then it can lead to poor sleep. Inositol builds up in neurons. And another thing that I've added in a few patients is organic lithium, also known as lithium orotate, not a prescription. It does not have the renotoxic side effects or a lot of the side effects. You don't want to add it in if you're actively trying to conceive still, because it is lithium. And one of the side effects of lithium is that it depletes inositol in the CNS. So you stack your inositol, a touch of organic lithium, a bit of L-theanine the last 7 to 14 days of the cycle, and that can help.
Yeah, absolutely. I think that is a good summary.